Thanks for joining us. My name is Nick West and I'm the Chief Medical Officer here at Shockwave Medical. I'm delighted to be joined today by Dr. Alfonso Girado of La Paz University Hospital in Madrid. The reason we've got together is to talk about a trial that he's recently completed and presented indeed at EuroPCR 2024. It's the roller coaster Epic-22 study. I can tell you the manuscript is currently under review, so we'll be seeing more of the data going forwards, but let's talk with Alfonso about this study, some of the whys and wherefores, and delve into why this study is important. So Alfonso, welcome. Thank you very much indeed for joining me today.
Hi, Nick. It's my pleasure to join you this time to discuss about the trial.
So perhaps you could start off by telling us, why did you design this trial? What was the motivation behind the roller coaster study?
Yeah, as you know, coronary calcification is one of the worst enemies of us, of interventional cardiologists, because it hampers the results, they increase the complications, and all this. So we have different plaque modification techniques nowadays to solve these issues. However, we are deciding which technique to use according to our experience, according to some observational data, but there is a lack of randomized comparison between advanced plaque modification techniques. So this is the main reason for designing this trial, to compare, to add more randomized data about these advanced plaque modification techniques in this setting.
Yeah, and I think, as you say, that fills a very important evidence gap. There are plenty of observational studies, and I think that anyone who's practiced as an interventionist will have their own favorite technique, one they are familiar with, they have the skill to execute it. But we tend to rely on what we know rather than going ahead and it's very difficult to compare between the single-arm data that are out there, exactly as you say. So tell us, in roller coaster, which techniques did you assess, and what were you looking at assessing? What were the measures?
Okay. Yes. Coming back to the last question, I really think that randomized evidence is crucial, but the experience and observational data are also important. So probably after this trial that we are commenting, we will continue deciding based on this data and also in our experience. So these both parts of our practice are important. And regarding the second question, we randomized patients in this trial comparing three techniques. A rotational atherectomy, that, as you know, has been the therapy of choice in the last decades in resistant calcified lesions, lithotripsy, and laser, an excimer laser. And these were the three treatment arms in the trial.
And I think it's very interesting, because I would imagine that many centers don't have access to all three of these therapies. So it's important that you were able to do all three in your center, because it removed one source of variability in the study.
Yeah, this is one of the main advantages of working in La Paz, in Madrid, because we have all these techniques, and we thought that it was interesting to use these three techniques. Now we use also orbital atherectomy and all different techniques, but at that moment, at the moment of the initial of the study in 2019, these were the techniques, and the primary endpoint was the extent expansion by OCT. We are using intracoronary imaging in all our complex PCI procedures, so as we believe it should be done, and this was the primary endpoint. We analyzed this by an intention to treat analysis in a non-inferiority fashion, measured by an independent core lab blinded to the treatment arm. And we use rotational atherectomy as the reference treatment. And we calculate a sample size of 168 patients, more or less, 170, to achieve our objectives.
So I think you raise a really good point here, and the design clearly is appropriate for this kind of comparison, because I think when we think about plaque modification techniques, although everyone in interventional cardiology is rightly obsessed with event rates and what happens to patients, the truth of the matter is the definitive therapy is not necessarily the calcium modification in this case. The definitive therapy, the destination will be a stent. And so if you look at more than the acute outcome, you're probably measuring as much the effect of the stent as the plaque modification. So using a metric like stent expansion, and we know there are a wealth of data that talk to the minimum stent area and the outcome and the degree of stent expansion. So using that, I think, without putting words in your mouth, enabled you to do a smaller study. If you'd have relied on clinical endpoints, it would have been a much larger study, I think.
No, it's true. It's true. We obviously we have secondary endpoints as MSA, clinical success, procedural success, and also we will do a follow-up in 1 year. But for the primary endpoint, we really believe that stent expansion by OCT was the crucial point in this kind of trials.
So let's not keep anyone in suspense. Tell us what you found in the study. What were the primary results?
Yeah, it's important to remark that the baseline features were similar between the three arms. And also the angiographic features were also similar. 65% of cases of patients were stable coronary disease at admission, and 35 acute coronary syndromes. It is important, an important finding in comparison with the disruptive trials, for example. And in terms of the device success and the need of a second technique, we observed that we had a similar rate of need of second advanced plaque modification technique between 10 and 14% between the three arms, without significant differences, but for different reasons. That is logical. In the arm of ROTA, for example, the main reason for a need of a second technique, advanced technique, was that the lesion was undilatable after ROTA. And for example, in the arm of lithotripsy, the main reason of the need of a second technique was that the lesion was uncrossable by the shockwave balloon. It's important to remark that the randomization was performed immediately after angiography. After observing a moderate to severe calcification by angiography, we randomized the patient. So probably in some cases, we had an uncrossable lesion before applying the technique. And some of these cases went for lithotripsy, for example. No? This is important to understand, or to try to understand, the results, as the primary endpoint is an intention to treat analysis. So, for example, with this rate of second technique between 10 and 14%, for example, one patient that was initially randomized to ROTA that need a second technique because the lesion was undilatable after ROTA and finished with lithotripsy, the final effect in stent expansion probably is a combined effect. It's a rotatripsy procedure, for example. No? And on the other hand, if you have a patient that was initially randomized to lithotripsy and the shockwave balloon didn't cross because it was a critical stenosis and finished with ROTA, the final effect in stent expansion probably is only because of ROTA. And this result is assigned to lithotripsy because it was the initial arm in an intention to treat analysis. So this is important to try to understand the results. No?
That's important because that represents real world practice.
Yeah.
So we're not forcing patients to have one kind of treatment, because in the real world, you may start off fully intending to use one technique, but the truth is you're going to need two. And as you've pointed out, the treatment effect is an aggregate of those two therapies on the lesion, because there is no one size fits all for this, and every patient is different. Their lesion may behave differently. And I think that's a very important part of the study.
No, I fully agree. I'm quite convinced of the complementary nature of all these techniques, and we should choose one firstly, or think of using two by the beginning of the procedure. But one message could be that there is no only technique that can treat all the patients, because we have 10 to 14% of crossover in the three arms. But to interpret the results, this is important because we are assigning the result to the first technique, and probably the effect is done by the second technique or by a combination of the effects. So to come back to the results, the device success was similar between the three arms. The crossover rate was similar, but for different reasons. The procedural success rate or angiographic success rate, TIMI-3 flow, final stenosis less than 20 or 30% was similar between the three arms. When we look to the OCT analysis, the only mandatory OCT was the final OCT to analyze the stent expansion, but we recommended OCT before the plaque modification technique and immediately after to analyze the effect of the device. And we observe a similar MSA in the three arms, a similar MSA, with more patients with more than one fracture in the arms of lithotripsy or laser compared to rota. This is an interesting finding. And in terms of stent expansion, lithotripsy achieved the non-inferiority threshold compared to rota in the intention to treat analysis, but laser didn't achieve this non-inferiority in the intention to treat compared to rota. Taking into consideration all these things of the intention to treat and the crossover, we also analyzed the same comparison using using the last technique used and only analyzing the cases without a second technique. And in these two different analyses, lithotripsy achieved again the non-inferiority threshold compared to rota, and the advantage of rota against laser observed in the intention to treat analysis disappeared. So in the analysis by the last technique used or in the analysis only in the cases without second technique, we didn't find any differences in stent expansion comparing rota and laser. Regarding complications, the complications rate was quite low in the three arms without significant difference, probably because of that. The numbers were quite low, but they were numerically lower with IVL. For example, we define severe procedural complications as death, perforations, a blood vessel closure, stent thrombosis, or flow-limiting dissection, one of them. And in the arm of lithotripsy, we didn't observe any of these severe complications in the procedure. And we had 4 severe complications, perforations of them, 2 in the arm of rota, 2 in the arm of laser. The 4 of them solved in the cath lab successfully. We didn't have any death, any stent thrombosis in the whole trial, any blood vessel closure. We had 1 side branch closure in the arm of lithotripsy. However, we solved with a 2-stent technique in the procedure without any clinical impact, and we didn't have any complication during the admission related to the plaque modification technique. So these are more or less the findings of the trial.
Maybe let's just talk a little bit about each of those 3 principal results. You've already outlined at a very high level. It was a very similar patient group, no differences in the demographics and the procedural factors for these cases. Very similar success rates and final exit stent expansion and MSA. There were differences in the need for the secondary technique. And as you've outlined, I think for rota, you were saying the major issue was that after rotablation, lesions remained undilatable. And of course, this is potentially one of the shortcomings of rotational atherectomy. You can relieve the stenosis, modifying the more superficial calcification, but the deeper calcification may not be reached because the burrs just don't get big enough.
Yeah.
In a similar way, you mentioned that for IVL, the issue was crossability, and that's something we hear a bit, and we are, as you know, working on more deliverable devices, which we hope will be coming out in the not too distant future. And often you need adjunctive therapies to assist the crossing of the IVL device. And out of interest, we've just completed a study in Japan called the Dual PrEP study, which looks at this idea of combining rotational atherectomy with IVL. We hope those data will be presented at TCT later in the year, so some interesting data coming out there. But of course, one thing I think we do want to mention very briefly is the safety analysis. So in terms of procedural complications, which is one of the things that everyone fears when you're doing advanced plant modification techniques, you outlined that, as we expect, any calcified lesion you treat, no matter how you treat it, the risk of dissection and perforation is always higher. And I think as interventionists, that's something we have to accept. But I think without reading too much into the safety data, there were differences. And I know the numbers are small here, but there was a reassuring signal for IVL. And I think if we think about the safety and the ease of use, I think that's something that we would like interventionists to understand, that first of all, the IVL balloon is everyone can use a balloon. Every interventionist can use a balloon. And I think what you've shown is that it's safe to use in heavily calcified lesions.
No, it's true. It's true. This is the reason, in my opinion, of the exponential growth of lithotripsy all over the world. It's easy and it's effective and safe, no? Compared with the other techniques. No? So in very specific centers with experience with rota, orbital, or laser, you are used to do procedures with these techniques. But in general, all interventionals can use a balloon, as you said. No? It's just inflate, press a button, deflate, and that's all. No? I don't know, probably one limitation of the trial is the sample size, because it's a small number of patients. But we have similar results of the observational registry we had in the literature, the ROTCAT, the replica trials. It's important to remark that in this randomized trial, we observed similar data than the real-life lithotripsy registries, with 35% patients with acute coronary syndromes and a similar complications rate with the ROTCAT trial. Probably when we are facing complex PCI, we had to take into account these 3% of complications, but that was the numbers in the arm of rota and laser in our trial. But probably, I don't know if 0% is real with 171 patients. Probably with more patients, we had one complication, but it's quite safe.
Great. Well, thank you very much indeed for delving into the trials, a bit of a deep dive here. I think as we close, you've identified, you've very nicely explained to us the why of the trial, how you executed, what the results were, and you've touched on some of the limitations in terms of, as you said, the sample size. But this is exploratory and hypothesis generating. Maybe just for the watchers or listeners, tell us in one or two sentences why this study is so important for clinical practice.
Yeah, I think the importance of this trial is that we add more randomized evidence for the things we were doing before this trial. So probably after this trial, we are in the same position than before this trial. We will continue selecting the therapy or the combination of therapies of plaque modification techniques according to our experience, according to the patient, according to the lesion type, according to the calcium pattern. But now we have more randomized evidence to support our decisions.
Great. I think that's really clear. Alfonso, thank you very much indeed for sharing these data. I think, as you've put it very nicely, the addition of randomized evidence in this study, it confirms the importance of device selection for complex calcific disease, and it also highlights the complementary nature of the techniques. Alfonso, thank you very much indeed for joining us today. I really enjoyed the conversation, and we look forward to the publication of the manuscript.
It was a pleasure. Hope to see you soon.